I would like to spend, hopefully that will stop recording in a minute. But we'll go over all of this, and then I'm going to sort of dive in a little bit deeper, hopefully to chapter 38 and 39. Well, actually, really just 38, but maybe 39 as well. Let's see what I need to do. Okay, I make it almost 2, so I really want to sort of get on with this and not waste too much time. What group wants to go first? Don't all shout at once. Why don't I
Which
pick?
drug do you want us to do?
So, are you group 5?
Yes.
Okay. So let's look. Group 5. Let's see. Well, let's do. You had tetracycline, didn't you?
Yes, we did. Give me a second.
Let me find tetracycline. What page is tetracycline, just to let everybody know? Oh, I've got it. Page 602. Right. Let me see if I can find how you've. I'm trying to figure out how you've. How have you uploaded this? Oh, I see. Gotcha. Aspirin, tetracycline. So let me click.
Our mechanism of action was inhibition of protein synthesis in susceptible bacteria. It inhibits growth and kills a wide range of rickettsia, chlamydia, mycoplasma, as well as gram-negative and gram-positive bacteria, spirochetal infections such as syphilis and Lyme disease. Dimeclocycline, in particular, possesses a unique drug effect. It inhibits the action of antidiuretic hormone, which makes it useful in I'm not sure what this acronym is for, SIADH.
Syndrome of inappropriate antidiuretic hormone.
Okay, perfect. And we also have a phosphorylation effect in microorganisms. And I think that has to do with the coating of the organisms.
Okay.
For indications, we're going to use it for rickettsia, chlamydia, mycoplasma, gram-negative and gram-positive bacteria, as well as syphilis and Lyme disease. Our example drugs are demaceclcycline, doxycycline, that's probably the most famous one, and tigecycline. For overdose management, we couldn't find a lot, so we said it was to stop the medication immediately.
Yeah, absolutely.
Because it may cause hepatotoxicity. For interactions, a few things that reduce the drug's effectiveness are antacids, dairy products, calcium, and antidiarrheal drugs. Also, if taken with digoxin or warfarin, it will increase the effects. And it absolutely cannot be used with methoxyflurane because it can be fatal. For contraindications, it's contraindicated for patients with allergic reactions, pregnant persons, breastfeeding, children less than 8 years old, people with liver problems or renal diseases.
Awesome. Now, I just want to add a couple of pieces in here with tetracyclines. So the big issue is, remember, these young people, it binds to calcium, right? So the problem is you got to be careful that giving it to young children and also breastfeeding mothers, because it binds to calcium. It can have a graying effect on the teeth. So that's one of the big issues with these tetracyclines. So Bear that in mind. And it talks about it under the adverse effects, just FYI. It causes this discoloration of the teeth. The other biggie as well is photosensitivity. And that's one of the things.
Oh, I'm sorry. I totally missed that.
Okay.
We had another
This is
section.
why we're doing this.
We also had adverse effects. We had fever, headache, permanent tooth discoloration, which is what you were talking about.
Yeah.
We also have retardation of fetal skeletal development, diarrhea, gastric upset. We also have hepatotoxicity, eosinophilia, neutropenia, thrombocytopenia, hemolytic anemia, exfoliative dermatitis, Stevens-Johnson syndrome, angioedema, toxic epidermal necrolysis.
Awesome. That's fantastic. Thank you. So let me see how I close your thing out a second. This is one of mine that just to cheat sheet. So let's go next to where do I want to go? Let me move that. Sorry, cancel. Let me move mine. All right, do you want to do NSAIDs next, or do you want a different group? Well, let's do the same group by group. So let's do NSAIDs. And I really just picked one. So this is chapter 44, by the way, guys. So
does anyone from our group want to present NSAIDs, or should I do it?
They're making you do all the work, are they?
No, I'm just asking.
If you want to do it, you can. You present it so well.
Okay. All right. For NSAIDs, we have mechanism of action. This is ibuprofen, which is the prototype nonsteroidal anti-inflammatory drug in the propionic acid category. It's the most commonly used of the propionic acid drugs because of the numerous indications for its use. Okay. For overdose management, we didn't find a lot, but we found you should do lavage or induced diuresis. For interactions, it can cause minor transient elevation in liver enzyme levels. Hematocrit, hemoglobin level, and RBC count can drop if the drug-induced GI bleeding occurs, and the bleeding time can be prolonged. There's also NSAID-induced hyperkalemia or hypoatremia.
And do you want me to scroll?
No, that's okay. That was just accidentally copied. For indications, it's used for analgesic effects in the management of rheumatoid arthritis, inflammatory disease, osteoarthritis, degenerative disease, gout, dental pain, musculoskeletal disorders, and primary dysmenorrhea. For contraindications, we have drug allergies, any condition that can put a patient at high risk of bleeding, such as vitamin K deficiency and peptic ulcer disease. Patients with documented aspirin allergy cannot take NSAIDs. It's category C in pregnancy for use during the first 2 trimesters of pregnancy, but indicated as a category D, not recommended for use during the 3rd trimester. It can cause excessive maternal bleeding and neonatal toxicity during the perinatal period. It's also not recommended for nursing mothers. Anyone undergoing an elective surgery needs to stop NSAIDs, such as ibuprofen, at least 1 week prior to the procedure. All NSAIDs, such as ibuprofen, share a black label warning due to risk for adverse cardiovascular thrombotic events, including fatal myocardial infarction and stroke. There's also risk for gastrointestinal bleeding, and NSAIDs may counteract the cardioprotective effects of aspirin.
Yeah.
For adverse effects, we have NSAID toxicity, and signs include, most commonly in adults, tinnitus and hearing loss. An acute overdose of NSAIDs like ibuprofen can cause similar effects, but they're generally not as extensive or as dangerous. Symptoms of toxicity can include CNS toxicities, confusion, paresthesia, numbness, aggressive behavior, disorientation, and seizures. GI toxicity symptoms include nausea, vomiting, and GI bleeding. Treatment consists of administration of activated charcoal with supportive and symptomatic treatment initiated. It also has intense headaches, dizziness, cerebral edema, or cardiac arrests and death those can also be adverse effects.
Wow. And this is over the counter, right? An over-the-counter med that people buy all the time. And I just want to cap onto NSAIDs while we're talking. Chapter 44, there are some key terms that I want you guys to be aware of. On page 679, there's a pathway, and it describes basically, one's called the leukotriene pathway and one is the prostaglandin pathway. And when we're looking at a lot of these meds, such as ibuprofen and these NSAIDs, they can do one of two things. The leukotriene pathway, I think of more of your asthmatic patients. The leukotrienes are stimulated because of an irritant, and it goes down that pathway and you get bronchoconstriction, those types of things. And the prostaglandin pathway is the other one, where basically an enzyme called cyclooxygenase, and I can't pronounce it, but it's COX for short, is stimulated. And the problem with this is that's good. What happens is it causes vasodilation. It can cause vasoconstriction as well. It creates a different type of inflammatory pathway, which is what we're wanting it to do. That's what the body's natural mechanism is. I look at that type of pathway more as your arthritis type of pathway, slightly different inflammatory response. But one of the things that these NSAIDs do basically is block that prostaglandin pathway. And while we're like, well, that's a good thing, prostaglandins are actually somewhat protective, which is then why when we're blocking it, you get these GI bleeding. You can have obviously this reduction in cardioprotectiveness, those types of things where this element of the prostaglandins, of course, it's always a balancing act. You don't want too much and you don't want too little, but they can have somewhat of a protective effect in the GI tract and also in the cardiac system. So I do want you to be aware of that prostaglandin pathway, and what we're doing is actually blocking it. Okay, so as I say, as a result of that, then we end up with this GI bleeding, and as I say, the big thing to remember here that Andre was talking about is regarding the cardio side of it. Any patient that's had an MI, they cannot have NSAIDs. The potential for their for reducing their life expectancy is, I don't know what the percentages are off the top of my head, but the bottom line is it's not cardioprotective. In fact, the studies show that it will lessen their lifespan if they take NSAIDs. So aspirin is a whole different entity, and although it's classed as an NSAID, it's, think of it differently than the ibuprofens and those types of things. So anything other than aspirin, basically, if it's an NSAID, then you're not going to give it to your patient who's had an MI or who has some cardiovascular risk factor. Okay, so just be aware of that. That's a really big deal. And I'm trying to see where it is. Yeah, on page 681, it does talk about NSAIDs and their adverse effects, but this particular one is a really big deal. And on page 681, there's a paragraph regarding adverse effects. And about halfway down, it actually says prescription NSAIDs will be revised to reflect the following information. And it talks about, yes, it can be a risk of heart attack or stroke if you take an NSAID, that's a risk. But the risks increase, of course, with the longer and higher use. And patients who are treated with NSAIDs following a first heart attack are more likely to die in the first year compared with patients who are not treated with NSAIDs. So the bottom line is, if somebody's had an MI, you just don't give them NSAIDs. all right, other than aspirin, that is cardioprotective. So thank you for that. By the way, on the HESI, it's going to talk about things like what is the adverse effects of NSAIDs. That's why I put it in there. So, as I say, that protective prostaglandin that is normally there in our GI tract is being blocked by this COX, by this action. And so by the NSAID action. So we're blocking the activity of COX. So therefore prostaglandins are no longer working in the gut, which are protective, puts you at higher risk for things like GI bleeding. Okay, so that's what it's talking about there. So let's talk about aspirin. Let me see if I can click out of that. Is this helpful doing it like this a little bit?
It's kind of hard with the groups.
Because you're making you think. All right, who's going to talk about aspirin?
I can do it. The mechanism of action, it blocks pain impulses by blocking COX-1 in the CNS. It reduces inflammation by inhibition of prostaglandin synthesis, and it has an antipyretic action resulting from vasodilation of peripheral vessels. It also decreases platelet aggregation. We messed up the example drugs over here a little bit. I'm sorry about that.
So just
the adverse effects are GI bleeding, hepatotoxicity, hemolytic anemia, Ray's syndrome in children, anaphylaxis, laryngeal edema, and angioedema. For overdose management, we had lavage, monitoring electrolytes and vital signs. Interactions, it interacts poorly with alcohol, cefamandole, clopidogrel, eptifibatide, heparin, plicamycin, ticlopidine, tirofiban, ammonium chloride, and nizatidine, insulin, methotrexate, phenytoin, and valproic acid, as well as nitroglycerin, probenecid, and spironolactone and sulfapyrazone. Indications are mild to moderate pain or fever, including rheumatoid arthritis, osteoarthritis, thromboembolic disorders, transient ischemic attacks, rheumatoid fever, post-myocardial infarction, prophylaxis of myocardial infarction, ischemic stroke, angina, acute myocardial infarction, and Kawasaki's disease. Mm-hmm. And we also have contraindications, pregnant persons, breastfeeding, children under 12, children with flu-like symptoms, hypersensitivity to salicylates, tartrazine, which is FDC yellow dye number 5. It's in a lot of things if you look at your snacks.
Yeah.
GI bleeding, bleeding disorders, vitamin K deficiency, peptic ulcer, acute bronchospasm, granulocytosis, increased intracranial pressure, intracranial bleeding, nasal polyps, and urticaria.
Excellent. So there is a lot of information on aspirin, by the way. One of the things you want to be aware of, and one of the key terms is salicism, and that's salicate toxicity, aspirin toxicity. And of course, one of the issues with it is tinnitus. That would be one of the first manifestations. If they say to you, wow, I've got ringing in my ears, that would be your red flag that, this patient could in fact have, aspirin toxicity. Okay, so that's something to be aware of for sure. And that is on page 682. So I do want you to be aware of that. Then let's talk about, as I said, aspirin is the only NSAID that you would give to your post-MI patient, okay? Of course, you do still have the risk of GI bleeding. It is going to cause thinning of the blood. That is one of the things that it's going to cause, which in fact is helpful for your post-MI patients. But bear that in mind. The other things I want you to be aware of is sort of standard dosing. You could give 325 milligrams, but the baby aspirin, the 81 milligrams, apparently works just as effectively. So based on the fact that you could have toxicity, why not go with the lower dose anyway? You know, so it's just as beneficial. So you may as well go with that lower dose when you're trying to do things like preventing thrombotic events rather. It can also be used along with clopidogrel, some of these other blood thinners. So, you know, it can be used. Of course, Ray's syndrome. Ray's syndrome is something that I promise you is going to be on one of your exams or your HESI or something like that. It's a life-threatening condition. It's actually down the bottom of page 683, and I know we've talked about it before. It can be triggered by certain viral illnesses, such as flu, also chickenpox as well. And so you're not going to give aspirin because that could definitely trigger Ray's syndrome, okay? The other thing I want you to be aware of is on page 686, there is a whole section on Ray's syndrome. It talks about what the serious complications are, which is encephalopathy and liver damage. That's two of the most serious, obviously, serious complications resulting from this. Usually after a viral infection such as chickenpox or influenza, and sometimes aspirin is given to reduce the fever, so just don't use it for that.
What page are you on?
Beg your pardon?
What page are you on?
Yep, I'm on page 686.
Thank you.
Then on top of that, if somebody has had a vaccine, actually, you don't want to give, if your child has had a vaccine, you don't want to give aspirin to reduce the fever just because of this concern as well. It says right here, the syndrome is seen in children between the ages of 4 and 12. But it usually occurs at the age of 5 and 9, those types of ages. So please be aware of this. And then in this section right here, it talks about the different stages of Ray's syndrome and what potentially can happen. The stage 3 is sort of coma, rigidity, stupor, basically disturbed brain function, encephalopathy, and of course you've got some liver function toxicity going on there too. So it talks about the medical management of it and the support of it. So you may want to just be aware of that. Okay. Lakia, please mute yourself. I'll mute you. Sorry, I'll mute you. Okay. So excellent. Good job, guys, on those 3. So let's now, let me move this over. So who is going to go next? I think group 6 had their stuff in there, didn't they? Discussion group 6. You don't have it in there?
No, we didn't post it in there. I didn't know we were supposed to post it in there yet.
It says it in the initial thing. Please upload and post so that everyone can see what you've done. All right, who has posted, please?
I posted for group 2.
Group 2? Perfect.
But I posted it in discussions. Was that right?
Yeah,
okay.
Correct. Let me just go in here. Yeah, perfect. That's exactly how you did it. Awesome.
We did it off of paper. We didn't do a Word document. So is it okay if I read it off of the paper, or was that wrong? Were we supposed to do a Word document?
I mean, it would have been, the concept map was in there under extras, but that's fine. If you've done it on paper, that's fine.
We didn't see that. Sorry.
As long as everybody has the information, that's the most important thing.
Yes. And I can do, Leah, I'll do this one. Did you want to do the other one?
So you've got a cephalosporin, right?
Mm-hmm.
I figured I had to pick one for you because I was like, oh, they're going to get confused. Otherwise, as with the class, they're like, well, you don't know what to do. So I just picked one for you. Rocephin is one of the most third generation, it's broad spectrum. All right, go for it.
Okay. So you already said the name, but it's a third generation cephalosporin. The drug class is category B pregnancy. It is safe, effective, and it's an antibiotic. The mechanism of action is that it binds to penicillin. It binds to penicillin binding proteins. It inhibits peptidoglycan. It causes
It's all right, keep going.
It causes
hard to say.
cells to break down, which leads to lysis, of the cells, which is ruptures of the cells. It is metabolized in the intestine after excretion, and it easily passes through the blood-brain barrier. But it is not effective, although it's an antibiotic. It's not effective against fungi, viruses, or enterococci.
Enterococci.
For indications, it is a gram-negative bacterial infection. The indication is for gram-negative bacterial infections such as meningitis. The therapeutic effect is bactericidal effects, which is removal of the bacteria. So as long as the infection is gone, the bacteria is gone. That's the therapeutic effect. The adverse effect would be allergic reaction. I meant to say this for mechanism of action is that they're just like penicillin. So their makeup and the mechanisms are just like penicillin. So the adverse effects are allergic reactions. If you are allergic to penicillin, that's a contradiction. You would more than likely, almost guaranteed, be allergic to cephalosporins. Mild diarrhea, abdominal cramps, rashes, pruritus, redness, and edema are all adverse effects. Drug interactions are birth control, antacids, alcohol, iron supplements, probenecid, known drug allergies, and calcium infusions. In the book, it did. Oh, by the way, sorry, I probably should have started with this. It is on page
595 is where cephalosporins start, and actually 598 is where Rocephin is, just FYI.
It does not say that iron, it does not directly say that iron supplements are interactions, but iron is an interaction. So I imagine that iron supplements will also be an interaction. But you cannot administer this medication with calcium infusion. The contraindications are severe liver dysfunction and Miss Fletcher.
What? Hyperbilirubinic neonates. Children that have got too much bilirubin. You know, you may have seen them. They have to be under the lights. Babies.
I can't say that for anything.
They got too much bilirubin.
Patient teaching is limit dairy and acidic fruits. No oral contraceptives. You would take it once a day, being that it's long acting, and you would take it exactly as prescribed. You would not drink alcohol. You would monitor your iron levels, since iron is a interaction. You report any GI upset to your healthcare provider. You also encourage your patient to eat foods that prevent superinfections, such as yeast infections. So you would encourage yogurt. You would encourage them to eat yogurt to prevent yeast infections. You wouldn't encourage them to drink caffeine, and it is given through MI or IV.
I am.
Oh, sorry.
Yeah. So if you don't mind, I'm gonna tap onto this a little bit, cephalosporins. So the bottom line is we have penicillin. penicillin, as you know, was found. It was found naturally from mold originally. Cephalosporins basically are more of a semi-synthetic antibiotic. The thing is, as you said, one of the big things I wanted you to pull out was the concern of if somebody is allergic to penicillin, a lot of the time, because of the structure, it's very similar to penicillin, and therefore, if you're allergic to penicillin, you're often allergic to a cephalosporin as well. And that's a nursing thing to be aware of, because the medications don't necessarily end in -cillin, so you may not click that in fact it's very similar to penicillin. Now these are third generation. There's actually 5 generations of cephalosporins, by the way, and at the bottom of page 595 it just shows you the many different cephalosporins that there are. And they started out as gram-positive, which is your which is your strep, staph, and enterococcus. Those are 3, and we're going to talk about that in a little bit. And then they sort of slowly moved into gram-negatives and sort of being a little bit more of a broad spectrum. So the third generation, which is what this is, Rocephin, can be used, I think, for gram-negative and gram-positive, but it works a lot on some of the gram-negatives. So it can be used for things like gonorrhea, by the way. So if you work in the ER, a lot of the time you'll see somebody get a Z-Pak, and they'll get an IM injection if they've got some risk of something like an STI, like gonorrhea. So that's one of the areas that you may see it being used. It's used a lot. It's again, as you say, it crosses the blood-brain barrier. So again, it's fantastic for things like meningitis, right? That makes sense that we would give it for something like that. Couple of things that I do want you to be aware of with the cephalosporins. Let me see if there was anything. Yeah. One of the biggies, and you're going to see this with some of the other meds as well. This, 2 things. You mentioned about birth control pills. The issue really is that these medications reduce the efficacy of birth control pills, any antibiotic. And in fact, I think I said, like in one of my last classes, I had a student who had 4 children, and she said every time she was on an antibiotic, she got pregnant because her birth control pills didn't work. And I'm like, wow, maybe I would have figured that out after I sort of looked at her and she burst out laughing. But anyway, the other thing so it reduces the efficacy of the birth control pill. So teaching is that, right? Making sure that they use another form of birth control along with the birth control pill because of the reduction in efficacy. The other thing I need you to be aware of is, and this is all on page 596, the other thing is don't drink alcohol. A lot of these medicines can cause what's called a disulfiram-like reaction. And what happens is when they drink alcohol, they're throwing up, they're hypotension, diaphoresis. So they can have a lot of reactions with drinking alcohol with these types of medications as well, okay? So just bear that in mind. All right, what have you got next? You have, what's this one?
Glucosamine, I think.
Oh, okay, glucosamine. Yeah, I put that in there because of the, because that comes up on the HESI, right?
Sure. So glucosamine is like a natural sugar. It's an herb or a dietary supplement.
Yep.
And it's chemically derived from glucose. For
What
indications.
I'm sorry.
Huh?
What page?
Oh,
it's actually on page 688.
It's in a chart, like a yellow box at the bottom. I'm sorry about that.
688.
So for the indications, it's used to treat pain related to osteoarthritis or caused by osteoarthritis. It delays inflammation action in the cartilage, which is caused by the osteoarthritis. So for adverse effects, it can cause GI discomfort, drowsiness, headache, and skin reactions. Drug interactions, it may enhance the anticoagulant effects of warfarin, and it may also cause insulin resistance. So you want to teach the patient that the INR level needs to be measured frequently, and if indicated, the warfarin dose needs to be adjusted. And because of the insulin resistance it might cause, they may need higher doses of oral hypoglycemics or insulin. And also, they should avoid taking glucosamine if they're pregnant because there's lack of firm safety data.
Okay, thank you.
Thank
That's
you.
good. Yep. And as I say, that glucosamine has been on the HESEs, just like things like ginseng and ginkgo. So good. All right. Who has? Yeah.
Vanna, can I share for group 1?
Group 1? Is your stuff in there?
Yes, I put it in there, but I'm trying to figure out if I put it under the wrong thing.
No, it looks like something's there. Let me see. How many? You only had one? You had INA? You had 3.
We had 3 medications, but we thought that we didn't know if we were supposed to do all 3 of them, but we combined all the information, so I apologize. We just thought that they work, like they all were like chain linked to work with each other, but they all are for tuberculosis.
Wait.
Are they all there?
Yeah, wait. So I didn't know how to upload anything or anything like that, but I did work on what is it called? INH, and I also have information for Rifampin or something like that.
Well, Rifampin is here, but I do want INH uploaded. So maybe send it to one of your colleagues that can upload it for your. Yeah.
All of 3 of them works for tuberculosis. Where is it? Rifampin is it's an oral. You take it orally. It's an antibiotic for meningitis coccus disease and TB. You're supposed to take it. You're supposed to take the medication an hour to 2 hours before you go to sleep. If you I guess because it's a big medication, if you can't swallow it, you can add it to applesauce or jelly to swallow it. You're supposed to stay away from drinking and operating machinery. If you're pregnant, you have to let your doctor know. If you're on birth control, you have to let your doctors know also. It has anticoagulants such as Coumadin, warfarin. It gives you skin rash, sore throat, fever, jaundice. If you have those symptoms, you're supposed to call your doctor. It can occur in your urine, your stool, your saliva, sweat, tears. It gives you the effects are harmless, but you're still supposed to let your doctors know. And it also says, in the drug book, it also told us that you can't just store the medication anywhere, like how most people put their medication in the medicine cabinet in the bathroom. It says that you cannot do that because it has to stay away from heat and moisture.
Okay. All right. So let's just look at this.
For isoniazid. Okay, I'm just gonna call it INH.
Do you have well, just hold on one second.
Okay.
First of all, I want to let everybody know where they can find the information.
Oh, it's on page 652. Sorry.
Yeah, the bottom is 651, and this one's on the exam. Okay, this is often on the exam. And also sometimes I have seen the one above it as well. Rifabutin is also often on the exam as a TB med. Very, very similar, as rifampin. And again, same effect. It can cause, it's not harmful, but it can turn everything orange, any fluid, any body fluid. So urine, feces, your skin, sputum, sweat, tears can be turned a sort of orangey yellow color. So you do, of course, need to let the patient know about that, right? That needs to be one of the biggies that you tell them, otherwise they're going to completely freak out. You're going to be checking things like what? Liver enzymes, bilirubin, kidney function, all of those things need to be checked. And also the CBC as well, because as I say, it can cause, these types of things can cause some hematological disorders like granulocytosis, those types of things. So you do want to make sure that you're checking the CBC. Let's just see if there's anything else I want to say. Those ones, rifabutin, rifampin, those ones have been on the exam. And the big issue is this right here. Make sure this is something you teach as well. With all of these TB meds, they have to be given at the same time every day. You can't, let me just, yeah. What do I want to say about that? Yeah, medications for TB can last up to 24 months. So they may be treated for, a couple of years potentially. So they need to understand that it might be short term, it might just be 3 to 6 months, it could be 9 months, it could be up to 24 months, something to be aware. Compliance is huge with TB drugs.
Can I add something else in there?
Yeah.
They send you for routine checks, x-rays, because it attacks your respiratory.
It attacks your lungs.
Yeah. So they send you for routine chest x-rays. I think it said every 3 weeks to 6 months.
Where are you seeing that about chest?
I looked it up in the drug book.
What drug book?
The one that they gave us.
I don't know if I would go with that. I'm not sure that I'm not so sure about that they do chest x-rays every 3 months. That's a lot of chest x-rays. I mean, seriously. They're going to do things like AFBs. We'll talk about that in a second. But anyway, making sure that they're compliant is one of the biggest issues. They've got to take these meds at the same time every day. Now, the Department of Health are often going to come around and check on the patient and check on the families and things like that. One of the things they do are what is called sputum cultures for acid-fast bacilli. Normally you do like 3 consecutive morning specimens and then a repeat specimen several weeks later to see if it's negative. And if it is negative, then they're actually allowed out more publicly. But if they're not, then of course, they're still infectious. So I'm not sure so much about the chest x-ray thing, how often they do that. I don't see anything in the book about that. But let me clock out of this one and this one. Let me go. I want to get your other one up. Are you group 1? You're group 1, aren't you?
Yes, I'm uploading it now.
Oh, I see. You haven't uploaded it yet.
No, ma'am.
Okay. You want to talk about it while you're uploading it? Or someone want to talk about it?
Are we talking about the INH?
Mm-hmm.
Okay, so yeah, I don't know why. I'm trying to send it to her so she can upload it, but it's taking forever to go through. I'm sorry if y'all hear a lot in the background. My son is doing his thing. But so for the mechanism of action, it's taken by it is taken up by the mycobacterial cells and it undergoes hydrolysis to isonicontonic acid, which reacts with the cofactor NAD to form a defective NAD that is no longer active as a coenzyme for certain life-sustaining reactions pertaining to Mycobacterium tuberculosis organism. And I found that on page 648. The clinical uses is used alone or in combination with anti-tubercular drugs in treatment and prevention of clinical TB. The adverse effects is for it causes pyridoxine deficiency and liver toxicity. So the patient teaching for that would be to it needs to be given concurrently with vitamin B.
It's B6.
Vitamin B6 is what I'm sorry. So some of the contraindications, drug allergy, and then major renal or liver dysfunction. What else?
So let me help you out. Okay. So what I want to help you out with a little bit here, but I do need you guys to upload it. So you got to understand that isocyanide is the primary anti-TB drug. It's the most widely used. It's cheap. It can be used by itself or in combination. A lot of the times you're going to see combinations of TB meds being used, and actually on page 648, there's there's different types of ones there. And what they do is they have different mechanisms of action. So they can do like a 1-2 punch with the bug. All right. So, these anti-tubercular drugs can actually have more of an effect if you've got more of them working in different ways. So that's one of the things. A couple of other things you need to understand about INH is, and I want to say what pregnancy code it is. Does it say what pregnancy category it is?
Whenever I looked at it, it didn't say. It just said that it hasn't been shown to affect the fetus. It literally says TB infections, including both whatever most antibiotics. It has not been fully tested on the effects in pregnant women. However, the combination of isoniazid and ethabutyl has been used to treat pregnant women without tetrodotoxin.
Yeah. I mean, it's the first line med that is used. Now, a couple of things that I do want you to be aware: rifampin, isocyanide, all of these meds. Again, you've got to be careful with things like oral contraceptives with these as well. Again, the efficacy can be reduced, right? So, you got to help them understand that they're going to need to use another form of birth control, not just the birth control pills, because of the reduction in efficacy. Let's see what else I want to say about this. Well, there's a lot to be said. It does have an effect on B6. It causes peroxidine deficiency. Therefore, and this is a HESI question, you're normally going to give B6 with isocyanide. That is part of the teaching that they need to take that, all right, because B6 deficiency in of itself can be a big deal, especially for children as well. Let's just look as well. Some of the issues with these drugs: liver dysfunction, fatigue, jaundice, nausea, vomiting, dark urine. So anything like that, it should be your sort of ding, ding, ding that you're thinking, especially dark urine and jaundice, you're thinking of your liver dysfunction. You're checking your kidney function as well. And if they start complaining of tingling sensations in their fingers and their feet, it could be peripheral neuropathy, and that would be your B6 deficiency right there. Making sure that these patients understand what we've been talking about, certainly with the oral contraceptives, that they might need to be switched from a birth control pill to something that is going to be maybe a little bit more effective, especially with rifampin. On page 654, I want you guys to see the patient teaching component there. And I'm telling you again, B6 has been on the HESI related to isocyanide, which is why I'm bringing it out so much, and the birth control component. So these are the pieces that I've seen over and over again that you need to be aware of. Let me just see. Yeah.
Group 6 is ready.
Let me just, okay, I'll be with you in a second. On the exam, there has been a question related to when can a patient actually be, when's the effects start to take effect of these meds? And on page 648, one of the major things that we're doing here is reducing the cough, because obviously when the patients cough, all right, that's when they're coughing out this tubercle bacilli. That's what's going. By the way, it's droplet transmission. All right, so this is normally they're in I think it's a negative pressure room, and the issue is, of course, it's droplet precautions with these patients. So that's a big deal that you need to be aware of, droplet precautions. So within 2 weeks, the cough is reduced. So therefore, the potential of infectiousness is less. That's a big important piece, and that has been on exams. It does say as well, successful treatment, usually about 6 months, sometimes 12 months, sometimes 24 months, just depending on how rampant the situation is, how quickly it's being taken care of. I do want you to be aware of TB on page, let's see, 646. The Mycobacterium tuberculosis, all right? And it's airborne, aerobic, it loves air. So that's why it loves our lungs, right? That's where it's going to grow. So be aware of what this is saying. It flourishes with a large amount of oxygen. So it just makes sense that it's going to be in the lungs. So I would definitely be aware of that with this piece. And as I say, it is droplet precautions. So that's something that you need to be aware of as well. Where are the big risk factors? Where do you think the big risk factors are with these types of patients? Any idea?
I would say for like drug addicts and in people in poverty, just in general.
Yeah, it can be. Homeless, you know, poorly crowded, lots of crowded types of environments as well. It does say as well, you know,
like a jail.
Yeah, jail, absolutely. It says as well, foreign, you know, often most of us from other countries have had our BCG, by the way, and that's something else that you need to be aware of. And it is on page, yeah, it's on page 648. If you've had a BCG like myself or many other people that have come from other countries, then the problem is when you do a PPD, we're going to come up positive because we've been inoculated. So we don't tend to do that. We do a blood test instead. It's quantiferin gold test. and that tells whether we've got antibodies, okay? So just to let you know, if somebody's from another country, you might want to just ask, have you had a BCG? Because there's absolutely no point in me having a PPD. I'm gonna come up, you know, I'm gonna come up reactive for sure. All right, and so that's something to be aware of right there. All right. Who is going next? We're going to talk about antiseptics and disinfectants. Remind me about that. Who said they want to go next?
Group 6.
Group 6. All right. 6.
Lakia, Eric.
Fletcher.
Pardon?
Group 4. We'll go after group 6.
Okay. Group 6. Okay, sorry. Please make sure the group with INH that you upload that. That needs uploading, please. All right. Oseltamivir.
It's on there, Miss Fletcher.
Okay, as long as it's there. It's not for me, it's for your colleagues, right? I want them to have that information.
Okay.
So who's going to talk about oseltamivir? It's on the HESI, by the way.
Okay, oseltamivir flu use is Tamiflu. Therapeutic uses is used to treat flu symptoms such as stuffy nose, cough, sore throat, fever, chills, aches, tiredness. Less severe and shortens the recovery times by 1 to 2 days. Adverse effects is abdominal or stomach cramp, or tenderness, arm, back, or jaw pain, bloating, chest pain, or discomfort, diarrhea, watery and severe, which may also be bloody, drooling, and facial swelling. Contraindications, confusion. Oh, I think this says contradictions, not contraindications. Confusion, suicidal thoughts, delirium, chronic kidney disease, stage 3A, moderate, chronic disease, stage 3B, moderate, chronic kidney disease, stage 4, severe. Food interaction can be taken with or without food, although taking it with food can reduce the chance of feeling or being being sick. Nausea or vomiting. Administration, the medicine is to be taken only by mouth, liquid and capsules. And
stop right there. Okay, stop right there. Did you talk about the teaching?
I didn't do this one. Eric did it, so I don't know. I'm just reading what he put.
All right, so here's the deal. Guys, on page 633 is where you're going to find this information. It is on the HESI. It has been. One of the big things you need to be aware of is the question may ask something like the patient comes in, they've had flu-like symptoms for a day and they want something to take it all away. Well, one of the big teaching pieces is it's not going to take the flu away. It's not like an antibiotic. All it's going to do is reduce the symptoms. That's the first thing that you need to know, that it will speed recovery, but it's not going to completely take the symptoms away. Okay, it's not going to take the virus away. The second thing you need to be aware is that these medications need to be started within 2 days of symptom onset. Okay, so if the patient comes in day 3 of the flu, there's no point. They have to be started within the first 2 days of the symptoms. Okay, amphotericin. Who's going to talk about amphotericin?
Okay, you ready for that one? Action. Which one are we doing?
Amphotericin.
Okay, the action, they have fungogestic, fungicidal.
Fungal, yeah.
Indication, by mouth, IV, treat fungal infections. adverse GI, hypotoxicity, dizziness, tremors, hypokalemia, hypocalcemia. Did I say that right? Calcium? HOPOCALCEMIA.
Hypocalcemia?
Okay. Hypotension and hypoxia and dyspnea. Teaching, take as directed, report development of rash immediately, notify physician for dark urine, nausea, and jaundice. In addition, assess respiratory status daily after administration.
Okay.
Yeah, that's all they have.
Okay, so a couple of things. Just to let you know, I always used to call it amphotericol. It is an antifungal medication, and it is for systemic fungal infections. It's a really nasty drug, by the way. Excuse me. Normally have to pre-treat your patients, pre-med them with Decadron, Benadryl. It will literally, we used to say it will make them shake and bake. So you would start this med and the patient will just shake uncontrollably. And it doesn't matter how many blankets or whatever you put on the patient. So it is, as I say, for systemic. There is a form of it that's called liposomal, which is, it's a more of a lipid form, which is actually supposed to be less, it has less side effects, but it's still pretty bad. Couple of other fungal meds that I want you to be aware of that have been on exams. Or you've got ribavirin there. Let me just mention these couple of other fungal ones. So one of the ones I want you to be aware of is Lamisil. It's actually for, say, fungal infections of the fingernails, things like that, okay? Terbinafine is the name for it, and it's on page 660 and 661. We can use it for lots of different things. It can be used for ringworm. It can be used for tinea pedis, which is athlete's foot. Any of those types of things. So tinea cruris, tinea pedis, but it's an antifungal. It can come as a cream or an oral form. I want you to be aware that it can affect the liver. So of course you're going to do something like liver enzymes with this particular med. But on 661, terbinafine has been on the HESI as well. And it's also on page 662. So again, you want to be aware with these medications, if the patient has anything like jaundice or dark urine or clay-colored stools, then any of those types of things could indicate liver dysfunction, okay? And you're going to do liver function testing. Bear in mind with terbinafine, on page 63 in the little box there, it talks about the fact that this is usually long-term. So you're going to tell the patient they're probably going to be on it for about 10 weeks in order to clear up any sort of nail infection that they've got. Okay? All right. Gosh, people, leave me alone. I don't know who all these people are dinging away. And I've got the... Stop. Wow. All right, let's look at ribavirin, which is in the
ribavirin is normally given orally for treatment of HCV infection and via inhalation for respiratory syncytial virus. Addition of ribavirin to interferon therapy for HCV increased effectiveness and toxicity. Mechanism of action not well understood. Adverse effects: hemolytic anemia, conjunctival, bronchial irritation. I'm sorry, I don't know how to say some of these words.
Sorry.
Hemolytic anemia risk. Contraindication is category X. You have to be on birth control. Cannot get pregnant 6 months after. Cannot be given to male partners of pregnant women. Medication food interactions. Food can enhance the levels of ribavirin in your body. Ribavirin should be taken with food or just after eating. This will make it easier for your body to absorb the medication, and do not take it on an empty stomach, and swallow the tablet or capsule whole. Administration is by mouth as a starting solution in the drug reservoir, or a continuous aerosol administration, 12 to 18 hours per day, every day for 3 to 7 days. Patient teaching, take at the same time every day. Like I said, do not take if pregnant. Female must be on 2 forms of birth control and take exactly as prescribed, no more or no less. Take with food, nursing interventions, verify med order, review patient's health records to identify allergies or contraindications with other medications, prepare medication one patient at a time, educate the patient, evaluation for effectiveness. This drug works by reducing the amount of Hep C in the body in order to help the liver. It is not yet known to be a cure or prevent transmission to others.
Cool. So the big thing that I want you to know about this particular med, it's been on the HESI on page 633. Ribavirin, here's the thing, it's actually an inhaled type of drug, and it's used in the hospitals to treat children with RSV. So a respiratory tract infection, okay? Because it's pregnancy category X, this is a big deal, because if you're the nurse looking after that patient and you don't maybe even know you're pregnant, and you're giving this aerosol type of med, there is a potential for you to inhale this med. The precautions are so much that you even have to be aware, as it says right here, pregnant healthcare providers or those wishing to become pregnant must stay out of the patient's room when the aerosol form is being administered due to the potential of secondhand inhalation. And this also goes for the male sexual partners as well. So it's a really big deal. And it is used as well for Hep C, by the way. But as I say, in the inhaled form, that's the big takeaway that I want you guys to be aware of on this particular med, okay? Ribavirin, it's been on the HESI numerous times. So I just want you guys to be aware of that. It's for severe RSV infections. All right, what do we have? Who's next?
Group 4.
Group 4. How many groups have we got to go?
I think we're the last one, I think.
Has group 2 gone?
Yep, they did. Cephalosporins. Mm-hmm.
Group 3? Who's group 3? Who's group 3? Just out of curiosity, who's group 3? Oh, we haven't had gent. No, all right, let's do group 4. Okay. Perfect. All right. So I'm just trying to find who's who, because I do want to really quickly.
It's a little sloppy, but it's there.
All right, group 4.
I'm gonna do diflucan.
Which is which?
It is going to be the second one. I think, yeah.
All right, let me rotate.
Okay.
Yeah. All right.
Okay, so one of our drugs was diflucan. It's an antifungal. It starts on page 657, ends on 662. The generic name for it is fluconazole. It can be given orally and IV. It also says something about injectable, but I didn't know if injectable and IV were kind of the same, so I just kind of put them in one. It's a synthetic triazole antifungal.
What page are you on, by the way, for everybody?
657.
657. Thank you.
You're welcome. The mechanism of action is it inhibits cellular metabolism of fungal cells. It acts as a fungistatic or a fungicidal. It inhibits the P450 enzyme needed to produce ergosterol. Is that?
I don't know where you are. It's okay. Just.
Depending on how severe the problem is, it can be given IV, but they don't like to give it IV. You only give IV if the solution is clear, and if you do give it IV, don't add it with other medicines. A single dose usually is effective for vaginal candidiasis, which is also known as infection. Any patient taking this medication, you have to educate them that they also will need an alternative contraceptive. It weakens the protection of birth control. Indications for this medication is vaginal candidiasis, oropharyngeal candidiasis, systemic candidiasis, and cryptococcal meningitis.
Okay. All right.
You want me to stop?
I just want you to, the patient teaching is the big deal with this, with diflucan, which you already talked about. Think of the same thing, the disulfiram reaction, okay? No alcohol with this, okay? Contraceptives is another one as well. So I think you've touched on the biggies of what I wanted you to be aware of with that. All right, let's go on to the next.
I could talk about the next one. This is Sierra.
Okay. Let me just. Which is it? This one?
Yep.
Ciprofloxacin. Good.
Yes. So the class is going to be quinolone. Quinolone. Sorry. And then it's going to be an antibiotic. So like an antacid and antidiabetic. So it was the first to treat widespread use, and it's going to be generalized. I believe it was page 614.
Yeah, and there's an area on page 623 in the box that talks a lot about quinolones too. So just FYI. But yeah.
Yeah, I mostly used the drug guide for nursing students.
All right, 616 is the area, by the way, in the book. 616.
616, okay.
Yeah.
And let me see. I had the page in the drug guide, but I think I lost it.
Well, I really want to focus on what ciprofloxacin is and also the big issues with it. So
yeah, so it's mostly used to treat urinary tract infections. So common indications was anthrax. The mechanism of action is it destroys bacteria by altering their DNA. So
Can I chime in? Do you mind if I chime in a little bit on this?
Okay.
So actually, it's a broad spectrum drug. It can be used for lots of different things. Ciprofloxacin can be used for, we have ciprofloxacin eye drops and ear drops. You may have seen, when we talked about ears and eyes, ciprofloxacin is used. it is used as well, actually. It can be used for anthrax. So it's used for many, many different things. UTIs would be lower on my list of what I would use. I wouldn't use this initially for a UTI if I could help it. So
sorry, that's just what I read in the book. Okay.
You're reading it in your drug book.
No, I'm talking about, that's what I read in the pharmacy book, the pharmacology.
Okay.
I read both.
Okay, all right. I'm looking at it right now. But anyway, all right, keep going.
Okay, so interactions would be warfarin, calcium, magnesium, iron, so different minerals, zinc, sulfate. Definitely a patient teaching point would be dairy products, not to use dairy products when taking this medication. It was a contraindication. And then internal tube feedings. So adverse effects would be headache, dizziness, fatigue, seizures, suicidal ideation, pancreatitis, vaginitis, toxic epidermal neurolysis, and then Stevens-Johnson syndrome. And it's a black box warning. So definitely a patient teaching would be to not get pregnant.
So there's a few, I'm going to tack on to this. So ciprofloxacin basically is sort of like the first prototype quinolone that came out. So they tend to end in the name floxin. So if you see something with floxin on the end, it's one of these, usually a quinolone. They're good for gram-negative bugs and also gram-positive. It just depends. So the gram-negatives, it could be some of the GI ones, but then we've also got things like Streptococcus pneumonia. There's many, many different things that ciprofloxacin can be used for. So one of the big adverse effects, and this is a couple of them, the black box warning. First of all, they can cause tendinitis and, in fact, tendon rupture. And I have met a patient whose bicep ruptured on ciprofloxacin. So tendon rupture is a big deal with this particular med. That's the black box warning. The other thing to be aware of with ciprofloxacin is on an EKG, you can see what's called a prolongation of the QT interval on an EKG. So it has the potential for, dysrhythmias. So that's another big issue with this particular med. Ciprofloxacin can be used really well. It's a great med. One of the things as well with some of these floxins, like levofloxacin, is like a once-a-day dosing. So as I say, they're great meds. They can be used for, it's not just UTIs. It's many, many, many different bugs, both gram-negative and gram-positive. So just be aware of that. And I want to say on page 614 and 615, it talks a lot about Cipro, predominantly about Cipro, okay? Did you guys have anything on superinfections, just very quickly?
Yes, ma'am. It's right there up under mine. Go down.
Is it this one?
No, it's under mine, right there.
This one?
Yeah.
Okay.
Oh, Sierra might have uploaded it too.
Okay. So that's awesome that you've got a lot here. I really Mercedes, just really quickly, if you can in a couple of minutes, just tell me, because I really want to get through the other meds that we've got here.
I think Billy was going to do this one.
All
yeah,
right.
I can do it real quick.
Okay.
Thanks, Billy.
Superinfection, it's on page 586, 588, 589, and 620.
Okay.
And on page 586, number 1, it's an infection occurring during antimicrobial treatment for another infection resulting from overgrowth of an organism not susceptible to the antibiotic used. And number 2, a secondary microbial infection that that occurs in addition to an earlier primary infection, often due to weakening of the patient's immune system function by the first infection. Some of the symptoms of the superinfection are jaundice, dark urine, abdominal pain, fever, nausea with enemas. And on 588 says superinfection can occur when antibiotics reduce or completely eliminate the normal bacterial flora. An example is a vaginal yeast infection. Normal vaginal bacterial flora is reduced by antibiotic therapy and yeast growth is no longer kept in balance.
Yeah.
Another example is C. difficile infection known as C. diff. It's an antibiotic-associated diarrhea. Antibiotics disrupt the normal gut flora and cause an overgrowth of Clostridium difficile. Symptoms are watery diarrhea, abdominal pain, and fever. And on 589, superinfections from external source as opposed to normal body flora. An example is a patient with a viral respiratory infection develops a secondary bacterial infection.
Okay.
Antibiotics may be used to treat secondary bacterial infection. There could be colored sputum. It may or may not be, and that could be a sign of bacterial superinfection if it's present. And then on 620, fungal superinfection symptoms, fever, lethargy, perennial itching, and other atomically related symptoms.
Thank you, Billy. So I think that's pretty self-explanatory. I always say if you're taking an antibiotic, you want a probiotic, okay? Just FYI. All right, let's quickly move on to the group that has gentamicin and vancomycin. And what I might do for you guys is I'll try and do because I don't think we'll have enough time. After you've all got off here, I'll do a very, very, very quick synopsis of chapter 38 for you. That'll be tacked on the end of this. So, all right, group, who has gentamicin, vancomycin? Group 5, where are you? Group 5.
I think that's group 3.
Oh, group 3. Okay, whoever it is. Group 3. Group 3. Come on then. Group 3, any of you?
Someone else gonna have to talk because I'm at my doctor's appointment.
What? How many others are you? I mean, there's several of you. All right, I'm going to do it. I'm not happy about this. You've got how many people there? 5 people, and none of you can actually give this information?
I'll do it. This is Tiffany. I'll do it.
Thank you, Tiffany. I know you're not well.
So the first one was gentamicin. It's aminoglycoside. It interferes with the protein synthesis in bacterial cells wall by binding to 30 ribosomal subunits. The mechanism of action is indicated for the treatment of infections with several susceptible gram-positive and gram-negative bacteria, severe systemic infections of CNS, respiratory, GI, and UT, urinary tract. Contraindications is hypersensitivity to aminoglycosides, dizziness. Oh my goodness. Is it a way that you can scroll down?
If you don't mind, I hate to jump in, but I'm gonna have to for the sake of time. All right. So here's the thing with aminoglycosides. They're bactericidal. So when I say cidal, I mean cidal in the sense of homicidal or suicidal. Think of it like that. They're killers, okay? So they're potent antibiotics. They're great. They're very virulent, but they are virulent, and some of the side effects, as it says right here, neurotoxicity and ototoxicity. So these types of drugs, gentamicin and then vancomycin, both of these, we actually have to measure, vancomycin not so much, but gentamicin peak and troughs, okay? Because of the potency and the toxicity of these drugs. So what she's got here is very important: neurotoxicity, ototoxicity. Actually, it's nephrotoxicity should be there. So it's supposed to be nephrotoxicity, not neurotoxicity. And I can't alter this, but please bear in mind it's ototoxicity and nephrotoxicity. That's a couple of the issues that you need to be aware of. So you are going to monitor the liver enzymes, but of course also the kidney enzymes. And if the patient starts reporting of this sort of tinnitus or ringing in the ears or roaring in the ears, those types of things, then you've got the potential for ototoxicity going on. So I do want you to be aware of that. Now, how these drugs work, by the way, if you have a what's called beta-lactam drug, which is your basic penicillin, bear in mind that this penicillin drug is going to go in first. The penicillin goes in and makes a way for these bactericidal drugs to come in and just decimate the bug. They work together. A little bit like, remember how we looked at our inhalers and we've got our bronchodilator going in, opening things up, and then the steroid coming in behind it? Well, the same type of effect with this. It's a synergistic effect with the beta-lactam drug, your penicillin, and then, of course, these types of things like your gentamicin and your vancomycin. So one of the things I need you to be aware of is a peak level is drawn 30 minutes after the infusion, which would be the peak predominantly. The trough is always done just before the next dose. All of this is on page 611. Page 611. Okay, so I want you to be aware of this. And of course, what are we trying to do? Well, what we're actually trying to do is make sure that we give the minimum inhibitory concentration, MIC. So we want to give the minimum amount that is not going to cause side effects. Okay, that's what we're trying to do here. But a certain level above the minimum inhibitory concentration that's going to actually kill the bacteria, because we can kill bacteria. So I want you to be aware of that. What are these drugs used for? These drugs are for big guns, big sort of type of infections, basically very serious gram-negative type of infections can be used for gram-positive, but things like Pseudomonas, Klebsiella, certain types of Staph aureus maybe, which is a gram-positive. So be aware of that. Talking of staph, if you don't mind, do you mind if I quickly do this for you guys? Do you mind? You don't mind, right?
I don't mind because no one else is talking.
Yeah, okay. Vancomycin. So thank you for putting it out so beautifully, by the way. Let's look at where vancomycin is on. Looking for vancomycin. Anybody can tell me where it is quickly so I can help you guys. Where did you find it so I can tell everybody? Oh, vancomycin.
619.
Thank you. I got it. Yep, 619. So vancomycin, this is the one that's used for MRSA, for staph infections, okay? It can be used for, oral vancomycin, by the way, can be used for C. diff, okay? So I just want you to be aware of that. Also for vancomycin, anything, VRE, by the way, is vancomycin resistant enterococcus. So that's something to be aware of. So same sort of things. If somebody has any kidney dysfunction, any renal dysfunction or any hearing loss, you're not going to give vancomycin, and neither are you going to give gentamicin, by the way. So neither of these two. I want you to be aware of that. Let's see, and it talks about some of the things here: hearing loss, renal disease, big adverse effect right here, red man syndrome. Now, it doesn't mean that you can't necessarily give this med. It just means that red man syndrome tends to occur with vancomycin. And so you actually have to slow, when you start this med, you give it very, very slowly to see what sort of effect that it's going to have. And then you can titrate it up a little bit. But if somebody has a history of this, you can still give it. It just means you have to pre-medicate them and then give it very, very slowly as well. Okay, so it's not necessarily that it's harmful. It's just you'll literally notice that the patient's face and neck and upper body will usually turn red. And you do give this slowly. Again, you're going to monitor the trough levels. And it does say what the trough levels are. A trough level should be between 50 and 20, not higher than that. You normally give this drug over an hour as well, by the way. So all of that is on page 620 and 619. So let's see, there were a couple of other things I want you to be aware of. This has come up, antiseptics versus disinfectants has actually come up on HESES before. And on page 588, it talks about antiseptics versus disinfectants. So antiseptics, basically they have a low potency and they inhibit growth. So when we talk about inhibiting growth, we're talking bacteriostatic. All right. Disinfectants, which is what we've been using in the, as the cleaning products in the classroom, right? These are for non-living, like what we call fomites. So antiseptics are more for your living tissue. They're bacteriostatic. So I just want you to be aware of the difference there. And then disinfectants are what we tend to spray on non-living objects, higher potency, and they kill bacteria. They are bactericidal, right? Think suicidal, homicidal, and that will help you remember killing. They're a killing agent, so that's what they do. I have not had
what page was that?
What?
The page.
Oh, the page is 588.
All right, thank you.
You're welcome. 588. And so that was the only other one. Wow, we are at 326. Golly. What I'm going to do, there is so much. Listen to that lecture, please. Because that lecture really has all of this information and some more in there. And what I'm going to do is I am just going to, I mean, you're welcome to hang out, but I've got to get you to clock out, that's all. I'm just going to talk a little bit about penicillin, the basic antibiotics, and just go over that chapter 38 a little bit. It's a fairly short chapter, but I really want to just, we talked about cephalosporins, but I didn't get a chance to talk about your basic beta-lactam antibiotic, and I want to have the opportunity to do that. By the way, one more medication, which is metronidazole, and it's in chapter 43, metronidazole. And let me see if I can find the page for you. I think it's also in chapter 42, but anyway, metronidazole is on page 672, and it's an anti-prozoal type of drug. So, it's used for things like trichomonas, Giardiaris, bacterial vaginosis. It's used for a lot of those types of drugs. It's known as Flagyl. So you may have seen it used under the name of Flagyl. It can be used for things like colitis as well. So again, it has that interaction with alcohol. So I do want you to be aware of that. That's another one of those drugs that has that disulfiram type of reaction. Okay, and that's on page 672. So wow, we did a lot today. You guys did a lot. But I need you to listen to that lecture, because that lecture is basically going to help you with all of these meds that you guys talked about today. And what I'm going to do is just give you the opportunity to clock out. And while you're clocking out, I will continue talking, so at least you'll have the rest of this little bit about beta-lactams on the end of this as well. Does that work for you all? You've been very quiet today.
Yes, it's working for us.
It's working.
It works for me, whatever.
I mean, there's so much that I could talk about, quite honestly, and it's like we just scratched the surface, and I find it quite frustrating, but at the same time, I have to give you guys the opportunity to do some different things rather than me just lecture all the time. It has to be a little bit more interactive, and
Right.
so I try my best to make it interactive, but really what I want to do is just throw information at you.
I have to go to a doctor's appointment. So where are you going to post this recording? Like, how do I
will
access
post
it?
it as an announcement. I teach again at 6 tonight, so give me a minute.
Miss Fletcher, can
Yeah.
you repeat the name of the recording that you want us to listen to?
It's the antibiotic lecture. It's the YouTube antibiotic lecture that I want you to listen to.
Okay, thank you.
You're welcome. It goes into, and I'll try and remember to add, if you scroll down, you'll find it. It's the antibiotic lecture.
Professor Fletcher?
Yeah.
Can you just tell us one more time which chapters are going to be covered on exam 3?
Exam 3 is going to be complicated. It's going to cover a lot of different chapters. So I haven't really told you that yet. Why don't we focus on what you're going to do week 8, which is your HESI, and then on Monday we'll talk about quiz 3 and exam 3 for week 9. Okay.
Okay, I just wanted to start trying to put together a guide.
Leah, if you want to, remember the exam prep recording is on my announcement.
I went over that, but I wasn't sure exactly which. I have an idea which chapters it is, but I didn't know, was that all of them, or was there going to be, because I think the pituitary meds and stuff like that weren't in it.
There's quite a few different chapters there.
Yeah. Okay, so I'll just wait till Monday then. And
I would, and we'll go over it.
Okay, thank you.
You're welcome. All right, if you need to clock out, please, can you all, you can't see it. Goodness me. There you go. I'm sorry. All right, so while you're all clocking out, I will just talk for a few minutes. I wanted to try and at least see if I could get you as much information as possible, but you don't have to listen to this. As I say, I am recording it, so it'll only be about 10-15 minutes more, that's all. So at the beginning of chapter 38, it's got a nice little picture, and it just shows you the bugs. And then it also shows you a picture of gram-positive versus gram-negative. And when we talk about positive gram positive versus gram negative. What we're doing is we're staining the bug, and depending on whether it stains purple or whether it stains red determines whether it's a gram positive or a gram negative in a basic format. So if it stains purple, think P for purple, P for positive, okay? If it stains red, think, oh my gosh, red. It's gram negative. They're like the bigger, badder bugs, basically. Onomatopoeia there, all the bees. But anyway, gram negative as well. One of the reasons it's a bit more virulent and a bit more difficult to manage is because when you look at this little picture, you can see that this gram negative is more complex in structure as opposed to the gram positive. So that's why it's a bit more difficult to kill. It's got a harder time penetrating and actually getting into that cell. So that's the difference right there. A couple of things I want you to be aware of, some terminology. Health associated or other healthcare associated infections. We used to call them nosocomial infections, and we don't call it that so much anymore. Really, it's a case of me as a healthcare person going in a room. I've got MRSA all over me. I've come out of one room. I haven't washed my hands. I haven't done precautionary measures, and bam, I've given this infection to the next person in the next room. Okay, so healthcare associated infections, and that's just a basic one, but there's lots of different things that healthcare people can do to pass infections on. You know, we don't put Foleys in properly, so we can cause an infection that way. As I say, MRSA can be one of the things that is transmitted very easily as well. So just be aware of that. What's the best thing we can do? Hand washing. Yeah. I'm glad that some of you are still hanging out. That's awesome. Thank you. I'm not talking to myself. I was like, well, I might be talking to myself, and that's all right. I often do that anyway. All right. So bear in mind.
We don't have time for you to talk to yourself. We need the information.
I wake up at 2 o'clock in the morning thinking about patients, by the way, and like, oh my gosh, I need to make sure that patient had blah, blah, blah. It's just what you do, isn't it? By the way, I dealt with DKA yesterday. I had a patient who refused to go to the ER, and so I had to fluid challenge her and bring down her blood sugar and deal with her in the office. So I'm still citing IVs and all the rest of it, right? It was sort of cool. It was nice to do that. And she was happy. She didn't want to go to the ER. Talking of she was concerned about COVID, you know? So she was like, I don't want to do that. So I ended up treating her in the office. So anyway, that's a little aside. Anyway, just to mention, so disinfectants, right? What do? They're those bactericidal. They're the ones we spray all over when we're back in the classroom. Those are our disinfectants. And then the antiseptics, remember, they're the bacterial statics, okay? They're going to inhibit growth. They're not going to let the bug grow anymore or reproduce, okay? So, couple of things I want to point out, just terms that you may want to be aware of. Empiric therapy is one of the terms I'm on page 588 if anybody wants to be there. Make sure that if you suspect somebody has an infection and they need cultures doing, you're going to get those cultures before you start therapy. So if there's an order to draw cultures, meaning blood cultures or sputum cultures or swab or whatever it is, but specifically blood cultures, you're not going to draw those, you're not going to start the medications until you actually draw the cultures. You gotta do that first because it could skew the data as to what's actually going on with the patient. Okay, so it talks about it right here on page 588, and I want you to be aware of that. That's an important one. The other thing you need to be aware of is the cultures normally take about 48 to 72 hours to get those cultures back. Then when you've got that culture back, it'll give you what the bug is sensitive to, and of course what the bug is. And that way we can tailor the therapy more effectively. That's definitive therapy, okay? Prophylactic therapy as well is something that we might do. Say someone's going for surgery or something of that nature. We may give some medications like a broad spectrum medication prophylactically just to cover them, depending on the procedure, for instance, like maybe a open heart, like a cabbage or something like that, or GI surgery, something of that nature, that they may need their medication, an antibiotic, broad spectrum, before the procedure. So we talked about superinfection. I don't need to go into that. We also talked about obviously getting a good health history. You need to know not just, hey, what are you allergic to? Well, what type of symptoms did you have? So you need to know whether it's an anaphylactic type of reaction, or is it just they had a bit of diarrhea, you know? So that can make a big difference as to whether they're truly allergic or whether, you know, they just had a bit of a side effect to it. So you definitely need to know what the reaction was and document that. Again, the other thing that was brought out regarding, hey, I'm allergic to penicillin. Okay, that's documented in the chart, but make sure you're aware that these cephalosporins that we mentioned a little bit, the patient can have a cross sensitivity to that as well. And as a result, you know, the cephalosporins can cause an allergic reaction too. All right, page 590. I'm just going to mention sulfonamides. It's an antimetabolite. The big one that we tend to use really is Bactrim. Bear in mind, what did I just said? Sulfonamide. So, you know, if a patient is allergic to sulfur in any ways, yeah, you're not going to give this, right? Antimetabolites, by the way, they require what's called exogenous, external, endogenous, exogenous, yes, exogenous folic acid. We don't produce folic acid. We have to take folic acid in exogenously, by the way. And these sulfonamides, what they do, they don't actually go in and burst the whole bacteria. They don't destroy it that way. They inhibit the growth. And what they do is they inhibit the bacteria synthesizing folic acid. And you need folic acid to actually, for growth. All right, so it inhibits folic acid. That's what it does right there. And so I just want you to be aware of that mechanism of action. What do we tend to use it for? We use it for a lot of different things. Gram-positive bugs. These are the ones, like I said, they stain purple. These are your staph, strep. Anybody ever had a strep infection? And enterococcus, those types of things. And they can be used, they normally have a high concentration of gathering in the in urine. So as a result of that, they actually gather in the kidneys. I apologize. So they gather in the kidneys. So these are great meds, Bactrim DS, to be used if somebody's got a UTI because of the fact, the high concentration in the kidney, that's how they get eliminated. So these are wonderful, I would say pretty much first line treatment for UTI, okay? So things like E. coli as well, Proteus, and it says Staph aureus as well. So by the way, if somebody has a UTI, you can give them something like Pyridium. just for a couple of days. Can't give that for long. But Pyridium actually is sort of like a, has a sort of analgesic effect on the bladder. It stops the bladder from spasming. So it's like an antispasmodic. So that actually helps with the pain with the UTI, just FYI. So I want you to bear that in mind, and that's on page 591. Of course, the big contraindication is what? Allergic to sulfur, yeah? And again, look at these adverse effects down the bottom here. Sulfur reactions, if anybody can see them, you know, erythema multiforme, photosensitivity is a big one with this. And also be aware, because it's a sulfonylureas can also be affected by this particular antibiotic. It can sort of create a double whammy. So sulfonylurea is already going to lower the blood sugar. You put this on top of it, and the patient can actually become hypoglycemic. So just be aware of that. And also it can upregulate the anticoagulant effect of warfarin. So has quite a lot of side effects there. Again, any antibiotic, you're going to teach a patient about the risk of lowering the efficacy of oral contraceptives, okay? So they need to use an additional form of contraceptive with these meds. All right, so we said sulfonamides work by interfering with the bacterial synthesis of folic acid. That's how we inhibit their growth. That's how we stop them growing and hopefully get rid of them, okay? And the biggie on page 592, cotrimoxazole is the big one here, or Bactrim DS. So I think we've pretty much mentioned that. All right, beta-lactam antibiotics. Well, you know, we had our penicillins, right? Penicillins, the natural one derived from mold. That's how we originally found penicillin. Beta-lactam, if you see here on page 592, and forgive me because I'm not a chemistry major, but I just want to point out this beta-lactam ring. If you can see this little area here, did everybody clock out? Sorry. Oh, she didn't clock out. I'm sorry, guys. I have to do this. I don't know why she didn't. This is the problem when people don't clock out. It actually makes me have to not just go in there, but then I have to go in the behind the scenes and do some stuff. All right. You can see this chemical ring, the beta-lactam ring, if you've got your books just here, this beta-lactam ring, which is the chemical structure of penicillin. So basically, it says here, we've got 4 different groups. Yeah, 4 different groups. We've got penicillins, we've got cephalosporins, we've got carbapenems, and we've got monobactams. I'm just going to really talk about the penicillins just a little bit. So what happens is some bacteria produce what is called beta-lactamase. So we have penicillin that goes in, it has this ring around it that protects the penicillin. It's basically this penicillin ring. It can go in and it can then, you know, inhibit if it needs to inhibit or whatever it needs to do. It actually is bactericidal, so therefore it's going to kill. It's going to go in like a killing machine and it's going to kill. It's bactericidal right here. Here's what happened, and this is why we had to move on from just beta-lactam penicillin. What actually happened is the bugs got smart and they said, hang on a minute. So this beta-lactam ring, if we create what's called beta-lactamase, maybe what we can do is break that bond down, and then we can carry on doing our thing, carry on killing. That's what we want to do. So we got smarter well, not me specifically, but researchers got smarter and they created beta-lactamase. They created a ring around it called clavulanic acid. So they created a ring around the beta-lactam ring. I think I'm saying this correctly. I feel like I'm saying it wrong, but I said it better in the past. But anyway, there actually is a beta-lactamase inhibitor. So now we have this coating around this beta-lactam ring. So now we can go in and still do what we're supposed to do and kill that bug using penicillin. The ring, though, will say something like clavulanic acid. So you'll see it known as augmentin now instead of amoxicillin. Does that make sense a little bit? Anybody? Anybody?
A little bit.
A little bit? So, you know, you had amoxicillin, beta-lactam. It's great. It's used to treat different types of infections, ear, nose, throat, all of those types of things, okay? But then the bug got smart and basically it created beta-lactamase. And that enzyme broke down that ring. And so we had to get smarter. So we created a coating that basically goes around that beta-lactam ring, okay? So that this beta-lactamase can't break it down. Now, of course, they got smarter, which is why we had to go on to other types of antibiotics. But my point is with this beta-lactam coating or clavulanic acid, for instance, or augmentin, I need you guys to be aware that it's still amoxicillin. It's amoxicillin now with a coating. Okay, so if somebody says I'm allergic to amoxicillin and then somebody orders augmentin and you don't realize that, then potentially you could, you know, create an allergic reaction. That's why I want you to be aware of it. Okay, does that make sense a little bit? I hope.
So the way we had a penicillin derivative, this is an amoxicillin derivative.
Say that again.
The way we had that penicillin derivative, which was modified, this is going to be an amoxicillin derivative.
Yes. So it started out as amoxicillin, okay, penicillin, with that beta-lactam ring. What happened is the bugs got smart. This beta-lactamase, which is the enzyme, was able to break that ring down, and it was like, drat, that's not helpful for certain bugs. So then we created this coating or clavulanic acid that goes around that ring as a protective ring. So it then becomes augmentin. Augmentin with a ring, augmentin with a coating. Does that help a little bit? Hopefully.
Yeah, and the name makes sense too. Augmented.
Yeah. So, so what do we use these penicillins for? Well, obviously they're broad spectrum, right? Gram positives a lot of the time. It does say the natural penicillins, not so good with gram negatives. Remember, these gram negatives are like the real bad boys. Okay, so your gram positives, your strep, staph, enterococcus, those types of things. And remember, your penicillins tend to end in cillin, but if they've got this clavulanic ring around them, then they're not going to have that name. And bear that in mind if they're IV, things like piperacillin, which is an IV form of penicillin, it has that coating. It's now called tazobactam, okay, Zosyn. So you have to be aware of the fact that these are still forms of penicillin. So what do we, one of the ones I want you to be aware of down the bottom here of page 593. By the way, penicillins generally are pregnancy category B, which is good, right? We can make sure they don't have a lot of reactions. That's a good thing for our pregnant women. Penicillin G down the bottom there has salts in it, and it actually creates like a white paste. So bear in mind, These are only given IM. You can't see me, but if I was standing up, you'd see I'm patting my glute right here. These are for IM only. You don't give these IV. It's like a thick white paste. So you wouldn't want to push that. That'll be fatal for the patient. So it does talk about that there. It's a great medication for things like syphilis, by the way. Let's see what else I want to talk about. I think that was pretty much it, actually, because then we're on to the cephalosporins, which we mentioned. Cephalosporins, semi-synthetic. That was like the next step that we went on to when we're beginning to realize about antibiotic resistance. We're, creating newer and newer antibiotics all the time. But I just want you to draw your attention to the bottom of page 595, where it has all of the listings of the cephalosporins, and it literally goes from 1st generation all the way to the 5th generation, and 4th and 5th are IV. So 1st, 2nd, and 3rd really is where I'm going with this. They started out more gram-positive, and as they got better and better and better, they were able to attack those really bad gram-negative bugs as well. So bear that in mind. And we also already talked about the allergic reaction issue between penicillin and cephalosporins. The 3rd generation are the ones that I'm sort of really was looking at. Let me just see. Yeah, cefotaxime, ceftriaxone, all of those 3rd generation ones, and that was Rocephin that I put in there as well. But of course, there's many others that we use. Carbapenems on page 598. To me, they're broad spectrum, but these are for the complicated, sort of complex infections, the big guns, right? So, and unfortunately with carbapenems, seizure activity can occur with certain patients as well. And again, you want to be giving these IV carbapenems slowly over 60 minutes. Okay. Let's see, what else did I want to? Yeah, I'm going to carry on for a couple of others. You can hang with me if you want, or if you need to leave, you can leave. Macrolides down the bottom of page 599. They tend to end in mycin. So azithromycin is a good example of that. So remember I told you it tends to be in the ER. People end up getting azithromycin or their Z-Paks and a shot in the glute for Rocephin. They tend to be covered for everything. So, but the mycins were developed in the 1950s, started out with erythromycin. These are bacteriostatic. So if anybody is around, anybody remember what that means as opposed to cidal?
It inhibits the growth?
Yes, exactly. You got it. So they're going to inhibit the growth. And you can see there's some of them right here, azithromycin, erythromycin. Erythromycin, by the way, we do use it, but it has a lot of side effects, a lot of GI issues with erythromycin. So we tend to use some of the other ones more. And erythromycin is great because more often than not, it's a one-time dosing, once-a-day dosing, as opposed to something like erythromycin where you might have to give it 3 or 4 times a day. Let's see, again, it says they're bacteriostatic. And I'm looking to see if there's anything else big that I want to bring out. Yeah, just FYI, erythromycin, by the way, it irritates the GI tract. So sometimes it's actually used for that purpose for patients that have like diabetics that might have what is called gastroparesis. So we actually might use something like erythromycin to irritate the gut and stimulate peristalsis. So just bear that in mind. Down the bottom of page 601, azithromycin, it's a macrolide. It's used for everything. Probably overused, and unfortunately, we're probably going to get, antibiotic resistance from that. But it is a great medication. The wonderful thing about it has good tissue penetration. It can become bactericidal, I think, at high dosages. But anyway, the bottom line is generally speaking, you only need to dose it once a day. And normally, if it's a Z-Pak, it's 2 doses on the first day and then 1 dose for the other 4 days. And I think that's pretty much where I'm going to leave it, because we did talk about tetracyclines, or one of you guys did. But the big takeaways in the nursing process in this section in chapter 38 that I want to say: making sure you draw your cultures before you start your antibiotic. That has been on tests. That's been on HESES before. Antibiotic resistance. Be aware of antibiotic resistance and what that means, and why a lot of the time we don't necessarily want to just go ahead and give an antibiotic for everything, okay? Sulfonamides. Bear in mind that if it's a diabetic and they're on a sulfonylurea type of medication to lower the blood sugar, it could have a double whammy effect and actually cause hypoglycemia. And also as well, thiazide, diuretics as well. So you could have more of a diuresis going on if they're on a thiazide. Penicillins, make sure you understand with penicillin the trade names, that it can end in a cillin, but as I say, if it is a IV form with or let's just say augmentin, for instance, the oral form, that it is still a penicillin, okay? I think a couple of other things, macrolides, your mycins, just be aware as well, even though this isn't things like your gentamicin, okay, that's slightly different. I want you to be aware you can still get hearing issue, tinnitus, hearing loss. So you want to be aware of your patient's hearing before they start these meds. Liver function testing, kidney function is another big thing as well. And one last thing with the antiseptics and disinfectants, a little box on page 604 talks about this as well. Making sure that the agent, if it's iodine based, that you recognize, you're checking to make sure your patient is not allergic to iodine, right? And then finally, as well, on the implementation, please make sure, generally speaking, as I say, I always say to my patient, if you're on an antibiotic, then you need a probiotic of some description. So I always make sure that they go buy a probiotic, or they're taking yogurt or kefir or something that has some sort of probiotic in it, okay? And make sure they don't take juices. A lot of juices nullify antibacterial action as well. And like I said, with the penicillin G, make sure it's given IM. It is like a thick white medication. You certainly don't want to give it IV. And patient-centered teaching. If they're on a birth control pill, they need to make sure they have some other form of contraception. Tetracyclines cause photosensitivity, and be aware of the disulfiram type of reaction with a lot of these meds. So basically, don't drink alcohol when you're on antibiotics is the takeaway. All right, I hope that was helpful, and I will plan on posting this as soon as I can, and I'll post a couple of little notes as well. Make sure you listen to the other antibiotic lecture, and I will see you all on Monday. Please reach out if I can be helpful though. Okay? Bye.
Thank you, Professor Fletcher.
Thank you.
You're welcome. I'm
Thank
glad
you.
some of you stayed to my really quick, but at least I got it in there for you. All right?
Okay. Thank you.
You're welcome. Bye.
Bye-bye.